folks. I'm very, very, very excited to introduce Dr. Bonnie T. Zima, who is a professor in residence specializing in child-adolescent psychiatry, vice chair for faculty development and associate chair for academic affairs, and associate director of the UCLA Center for Health Services and Society at the UCLA Semel Institute for Neuroscience and Human Behavior. What don't you do? It's amazing. I love it. Dr. Zima's research is dedicated to improving the quality of child mental health care with priority placed on children enrolled in Medicaid-funded outpatient programs and underserved at-risk child populations. Her research spans identification of high unmet need for mental health care among high-risk child populations and national pediatric hospitalization resource utilization and costs, validity and national quality measures for pediatric integrated care models, pediatric workforce development, and application of technologies in clinical informatics to improve child mental health care. Her research has received all 3 national research awards from the American Academy of Child and Adolescent Psychiatry. In addition, she is a member of the U.S. Child and Adult Core Set Annual Review Work Group for Center for Medicaid and CHIP Services, American Psychiatric Association Council on Quality Care, Behavioral Health and Substance Abuse Steering Committee for the National Quality Forum, and the AACAP Committee on Research. She is a consulting editor for the Journal of the American Academy of Child and Adolescent Psychiatry and deputy editor for the Journal of Child and Adolescent Psychopharmacology and distinguished fellow of AACAP and APA. It is quite an honor to have you here. Very excited to hear about the impact of COVID-19 on child mental health policies, early evidence, and future questions that we're excited to contribute to and discuss. Please join me in a warm welcome. Thank you very much for being here. And you have the mic.
Okay, well, thank you very much. And it's a pleasure to be talking, at least virtually, with so many of my UCSF colleagues and longtime friends. And so special shout out. And just to be very transparent, Dr. Stewart and I were chatting before this. And, it's really exciting in child psychiatry is that we really do have what I call the Underground Railroad in training and research across UCLA and UCSF. And so there's extensive long-term relationships across both of our programs. And so I'm happy to help out today with this talk. Today, I'm going to talk about the impact of COVID-19 on child mental health, just a brief overview of some of the relevant policies, a brief overview of the early evidence. And today I'm going to be showing some early data that I'm presenting at a live session at ACAP, and then also kick off at the end with some future questions. So I have, as far as disclosures, here they are. Our objectives, hopefully we'll have more knowledge about the scientific debate about reopening schools, a little more knowledge about recent research findings on this topic, and ideally reserving some time at the end to really kind of brainstorm about what our next step should be. So what is the policies related to impact of COVID-19? Well, the policy context in California, as we all know, is our governor signed an executive order ensuring that state funding for schools, even in the event of physical school closure, would continue. And that was published on the infamous day of March 13th, 2020. And what's really important here is that if you look at the executive orders for school closures for Los Angeles or for California and New York, they're within 1 day. And that means that that Monday, March 16th, schools were closed in the 2 largest public school districts in our country. And so here's the executive order in case you want to see it. And here, if you recall, following the national school closures, we really wondered during that summer after school closures more than a year ago whether schools would reopen. And it's funny in hindsight, you know how quickly things change. But anyways, the other thing that's important here is the American Academy of Pediatrics came right out of the gate with COVID-19 guidance for safe schools. And as a tradition, the AAP has always advocated for policy considerations for school. COVID-19 should plan with the goal of having students physically present in school. And here's some of the founders of AAP. And what's interesting about the American Academy of Pediatrics, if you look at its history, is it really sort of cleaved off of internal medicine with a very strong agenda towards social welfare and for children. And here are some of the key principles under the guidance for safe schools. Number one, safety. Number two, to continue to update policies guided by science. It's complicated, so they advocated for a multi-pronged approach to opening schools and through using partnerships. Already they were shouting out accommodations to reduce disparities, be adapted to changes in transmission risk, and I thought that was quite prescient given the concerns about the Delta variant now. And again, pioneer really leading for the overall health of children, communities, and thinking also about our educators and staff. What's important here is actually from the psychiatry side, the Academy of Child and Adolescent Psychiatry and the APA came together and also came out with a very similar statement. And if you look at it and you look at a crosswalk, you see that even though these two documents were developed separately, a lot of the key principles and values are the same. And if you look back to see where those values came from, it actually came from a very quickly turned around report from our National Academy of Science on reopening K-12 schools during the COVID-19 pandemic. And that was led by Keen Dibner. Okay. But as you can imagine with school reopening, there's some debate. And I think we're still in it. Some early evidence looking to see the impact of stay-at-home orders actually was done by a team that capitalized on a natural experiment that was happening between differences in shelter-at-home placement timing between Illinois and Iowa. And what they found here was prior to the stay-at-home order in Illinois, there were comparable trends in COVID-19 transmission between those two states. But then when Illinois put in their stay-at-home orders, there were increased cases in the border Iowa counties compared to those in Illinois. And what they did statistically was they estimated that an excess of 217 cases after 1 month without stay-at-home orders could be attributed to the lack of stay-at-home orders. What's important here about this next study was really one of the first that came out in JAMA related to statewide school closures and COVID incidence and mortality. And this was led by Catherine Auger at Cincinnati Children's Hospital. And what's really important here is they took a US population-based observational study. They looked at a very early time window, March through May 2020. What they did was an interrupted time series analysis, which is a fancy way of saying they looked at chunks of time over time. They looked to see, okay, when did closures of school happen? And also then look at the outcome of the COVID-19 daily incidence and mortality. And they standardized it by per 1,000 residents. And what they found, and this is why I think it made JAMA, was the Dr. Auger's team found that school closure was associated with a significant reduction in incidence of COVID-19 transmission, 62%, and mortality of almost 60%. And she also looked at the associations. She asked the question, okay, in large cities where the incidence rates of COVID are low at the time of school closures, do they do better compared to those cities that have already very high incidence of COVID transmission? And what she found statistically was that if you close schools, when in that area the incidence of COVID-19 is relatively low, it's associated with almost 130 fewer cases per 100,000 people over roughly 26 days. And what happened then later is a team came out to ask the question, okay, well, which is more effective in reducing transmission? Is it the actual school closure, or is it behavior changes happening in the community, like how much we're staying at home, not commuting? And what's really cool about this study is they actually used behavioral measures from anonymized cell phone or internet data. And what they did here and what they found was they found that if there was 1 day delay in school closure, it was associated with about 3.5% reduction in COVID incidence and almost a 4% reduction in mortality. But if you look at behavior changes, meaning how well areas were doing, banning gatherings, staying closer to home, less commuting, based on Google mobility data, he found that actually reduced the incidence of COVID by 9.3%, and you decreased mortality by almost 10%. And this was a very, very clever way, I think, to get at least a temperature of the relative impact of school closure compared to how well people were doing by staying at home and reducing their commutes. And here also was a survey, and I think no surprise here, but when it came out, it was quite validating. This team did a cross-sectional survey. They surveyed 730 parents of children aged 5 to 17 in early June 2020. And they asked them, okay, parents, how do you plan to send your kid to school or not? And what would be your conditions? And here, what was really important was you got a nice signal in this US cross sectional survey. About 31% at that time, parents said probably or definitely keep their child at home in the fall of 2020. And we saw that for sure in Los Angeles. 50% probably or definitely would send their child to school. And factors that were related to parents leaning towards keeping their kid at home: poverty, unemployment, job flexibility, their fear of COVID-19, and parents who perceive less challenges of homeschooling, which makes sense. So how about the impact of COVID-19 on child mental health? I think we can all agree, and we all have personal experiences, and that you know the COVID pandemic has put really an unprecedented strain on our children's mental health system. Our existing child mental health system, unfortunately, was not perfect to begin with, well known to be fragmented, ineffective, and unfortunately poor quality care in the community. The other thing too, under COVID, is we had increased need for child mental health care. And proposed mechanisms included concerns about increased child abuse and neglect, particularly since schools had closed and we were not able to report. Reduced physical activity, less access to school-based resources, increased distress among our parents, and also increased COVID-19 related illness and mortality, unfortunately, among the families we serve. And again, increasing concern that already, if our existing healthcare system is fragmented and already has existing disparities, and in addition, some of the increased need of child mental health care may affect children disproportionately, there would be also concerns that the accentuation of healthcare disparities through increasing social determinants of health that would be disproportionate would also accentuate our healthcare disparities. And so you see just some of the social determinants of health being minority, race, ethnicity, poverty, unemployment, access to poor schools, food insecurity, housing insecurity, and unfortunately, communities of color have higher COVID morbidity and mortality. So what do we know? This actually was one of the first studies, and it was pretty amazing how resourceful this team was. It came out of Hubei province in China, And this team quickly surveyed almost 1,800 children that were restricted to home from two primary schools in grades 2 through 6. And they had the Children's Depression Inventory and a screener for anxiety-related emotional disorders. And it was amazing. They quickly screened all the kids and reported this actually in a research letter. And it came out in JAMA Peds pretty quickly. And this was really one of our first signals around how child mental health was faring. And what they found was almost 23% of children in these two provinces reported elevated depressive symptoms. And of those that reported depressed, about half also said they worried moderately or a lot about being infected. And almost 20% of the children screened positive for anxiety. And here, more than a third also acknowledged feeling worried moderately or a lot about being infected. And with that, fortunately, in our Orange Journal, we had a early study also come out. And what was important here was, again, um, um, the investigators were capitalizing on an opportunity. The bottom line is that this team already had done baseline screening measures in a charter public middle school in Texas. And what they did is right after the stay-at-home orders, they did 3 post-monthly follow-ups with these screeners. Their sample was grades 5 through 8, about 322 kids. And what was interesting was that almost 3/4 of the kids in this sample were identified as Hispanic. And so they quickly wrote it up. And what's interesting here, and it got to have been published, because it was early, it was a Hispanic population. What was interesting was they did not use standardized screeners. Instead, this team had created sort of their own measure. And so based on that, they reported about a quarter of the children felt a lot or a whole lot lonely. Almost 50% reported their contact with friends was only through video and social media. About 25% of the children endorsed feeling stressed, and about 28% of the parents reported being distressed. And what they did is they actually had a subset of data on family functioning. And so they looked within that subset to see if better family functioning was potentially protective of lower mental health symptoms, which we know in the established literature is true. And what they did here is they found that, yes, better family functioning continued to be a protective factor during this early time period. This is an important, more recent study that just came out of JAMA Pediatrics. And what's totally cool about this one is they did a meta-analysis. And so what they did is they combined findings from 29 studies to pool about a sample of 80,000 participants. And what they did is they looked across prevalence estimates of mental health problems. And what they found was when you put all of these studies together during the first year of the COVID-19 pandemic, 1 in 5 children reported elevated signs of depression, and 1 in 4 children reported elevated symptoms of anxiety. And what's important here is also they asked, okay, well, what moderates this? And what they found was that 2 moderators, one was female and one was being older. And hold on to that because I'm going to show you later an analysis that might explain some of these early findings. The other thing, remember we had the big debate about schools and we're still in that debate. But one of the important questions is, what is the impact of changes in school on child mental health? And this is one of the few studies that has come out. And what's totally cool about this one is actually it was funded by the CDC. And they quickly put together something called the COVID Experience Survey. And it was contracted out to NORC, which is the National Opinion Research Center at University of Chicago, which has a huge kind of machinery to do US household surveys. And what they did is they quickly ran the survey of parents, children 5 to 12. They had almost 1,300 participants, and their data collection time period was really quite narrow. It was really just about, looks like 4 or 5 weeks in October, November 2020. And they turned it around quickly. And what they found was that at this time period, and this is a national household sample, they weighted it back, that 46% of our US children were receiving virtual instruction during this time period. And then if you looked across ethnicities, you found that of those children that were Hispanic, almost 2/3 were receiving virtual instruction or remote learning. And of our African American or our Black children, almost 64, almost 65% were receiving virtual instruction. Within this national household sample, we had about 31% of the kids were getting some in-person instruction, and about 23% were combined. And what was good about this was that a large majority of these children were in public school. Yes, there were some in private, but I think this was a really great way to get a temperature of what's going on in changes in classroom instruction for our country. And so what's important here is actually they divided the groups into those with virtual versus in-person instruction. And they found that those kids that were in virtual had much less physical activity. More than 60% reported decreased time spent outside. 86% reported decrease in in-person time with friends. More than almost a quarter said decreased virtual time with friends. And what's most relevant to us is that almost 25% of the parents of the kids who were getting remote learning or virtual instruction reported worsened mental or emotional health. And here among our parents in the survey, those parents of children that were virtual had reported more loss of work, more job stability concerns, more challenges with childcare, more conflict between working and providing childcare, more emotional distress, and more difficulty sleeping. So what about change in acute mental health service use, our early evidence? And I think this is where we probably get triggered by our tongue call. But nevertheless, this is a really important study that came out through our CDC, led by Dr. Rebecca Lieb. And what they did is they took data from the CDC National Syndromic Surveillance Program. And what that is basically encounters with emergency room have to be reported through public health. And so how it gets reported back to CDC, hospitals vary, but this is an ongoing database that they use to sort of survey ED use. And so what she did and her team was they restricted the sample to mental health ED visits, children less than 18, and they looked at the time period between January and the fall, October 17, 2020. And what they did then is that they took a data from the same calendar weeks from 2019 to compare. And what they found was right after school closures through about the first week, or second week, April 11th, sharp reduction in the actual number of mental health ED visits. And I think we all remember those days where people were afraid to come to the emergency room. But what was really important about this was despite the actual reduction in visits, when she looked at the proportion of ED visits for ED, she found a rise of 66% in ED visits for mental health. And so, and I want to show you here, this is what it looks like graphically, where the dotted line is the mental health related visits. In the top is the actual number of visits, and you can see the number go down in the spring, which is like weeks 12, 13, 14, around there. But then the second graph is the proportion of mental health related ED visits, standardized to 100 pediatric ED visits per week. And so what's important here is you see that dashed line from 2020. The proportion is much higher for mental health compared to the proportion of visits that were for mental health in 2019. And I think that really validates a lot of our experience. Here, what they did, again, very large descriptive data, is they sliced and diced it by age group. And the most important graph is at the bottom here, and that is showing adolescents age 12 to 17. You see the dotted line for 2020, much higher than the solid line for 2019. And again, you'll see this in some of the other data as well. But what's really important about the morbidity mortality weekly reports is that they can turn around publicly available data very quickly and report it out compared to the time lag we have with our scientific journals. So what's important here is we had some other early studies coming out looking at change in mental health service use. This study was led by Paulina Krass, who's a pediatrician at Children's Hospital of Philadelphia. And what they did is they basically looked into their EHR data, restricted it to ED visits for mental health, restricted their population to 5 to 24, and that's probably because pediatricians do see oftentimes conceptualize childhood through up to age 25. What Dr. Krass' team did was she looked at EHR data that was most available between April and December, and then she compared it back to almost a 2-year period that didn't match. I'm not sure why she did it that way, but very nice person nonetheless. And what she found was that there was, again, a reduction in ED visits following school closures, but again, the proportion of ED visits for mental health rose from 4 to 5%, on almost 6%. And when she looked to see, well, who's more likely to have a rise in mental health ED visits, it was female, white, older kids, and commercially insured. She was not able to find a difference among Hispanic versus not, but that's probably because in EHR data, that data field is often missing. So she probably didn't have enough statistical power to look at disparities by race or ethnicity. And here, just to show your findings graphically, you see in B, and I put the arrow, you see that the B is the proportion of ED visits for mental health. The arrow is when the onset of COVID hit, and you see the abrupt drop. And here was a really cool team of pediatricians from another children's hospital. And this team looked at used their EHR data. And I think we all are familiar with the Columbia screening measure. And what they did is they used the data from the Columbia screening measure that was in the EHR. And there they found higher rates of suicidal ideation in 2 months, March and July 2020. And based on the screening that was already in the EHR, they found higher rates of suicide attempts across 4 months. And this is what it would look like graphically on a bar graph. And this is a very simple little research letter, but I think really showed how quickly we could leverage EHR data to begin to feed back more real-time evidence. What's important here is there was a research letter that also came out recently, and this was run by Dr. Gill, and he looked at hospital discharge data among 42 US children's hospitals, and he looked at the very early time point, March through May, right after school closures ended, and then June through August, which I assume they picked because likely that's children were not in virtual learning anymore and were more likely to be on vacation and living at home. What main findings were, no surprise, among our US children's hospitals, an abrupt drop in all-cause hospitalizations, particularly for things like respiratory failure, cellulitis, and epilepsy. But what was really important about this research letter, and I'm really glad, this team included in their chronic disorders depression, and they included a category which included ICD-10 codes consistent with suicide and intentional injury. And what they found here was that in the spring, the drop was only 14.4% for suicide or intentional injury. And actually, in the summer, following school closures, there was a rise in hospitalizations for suicide and intentional injury. And these were children's hospitals. And what's important here is this is the main table, but you see here, what's is really important if you look under the p-value, suicide, intentional injury, you see a p-value of 0.98 for the first time period in the spring right after schools closed. You see a p-value of 0.99. So that means, and there's been no change when you look past in 2019 to 2020 in hospitalizations for suicide and intentional injury. And you see you see a significant change in the spring for depression, but that didn't persist in the summer. Okay, so that research letter, I liked it, but it kind of bugged me as well in the pediatric literature because it didn't drill down enough for me as a child psychiatrist as far as like, well, what types of mental health disorders might be driving some of that disproportionate ED use? And so I did a study with a very talented team, and here's the team. Includes Dr. Edgecombe from UCLA, who's a postdoc, Jonathan Rodin, statistician, Children's Hospital Association, Dr. Cochran, who is a professor in our School of Public Health, Dr. Harl, who's at University of Florida and is an informaticist, Dr. Patek is at Weill Cornell, and he too is a computer scientist. Dr. Singh is an outstanding statistician at UCLA, and Dr. Bussing is also one of the few child psychiatry health services researchers and is recently just stepped down as chair at University of Florida. So we had several questions. One was, does the percent change in ED discharges and hospitalizations between the spring and fall differ between physical and mental health disorders? What do you think? We'll see. And if there was a change in acute mental health encounters, did they vary by child sociodemographic characteristics or medical complexities? Here, trying to hit on the issue of disparities. The other question we had was, okay, if the proportion of mental health ED visits is higher than physical health, did the prevalence of the mental health disorders change before and after COVID when you see it for hospitalizations and ED use? And then we said, okay, well, if we were to get more granular as psychiatrists and as which mental health disorders contributed, well, and we see that disproportionate, then we might also want to ask for whom. So here were our methods. We did a retrospective cross-sectional cohort study. Our main outcomes were percent change in ED discharges and hospitalizations, stratified by all cause, primary physical health, primary mental health. Our timing was really important. We wanted to look pre and post national school closures. And so what we did was we matched calendar weeks. So we have a spring fall interval, meaning right after schools close through the fall, when some children may have re-entered, some children may have not, in-person school. And then also, given the prior literature, we thought it was really important to also slice it by season, which would be spring, summer, and fall of 2020. Our data source was the Pediatric Health Information System. And our study population, what we did was we limited it to children 3 to 17. We had completed discharge data for both years and time intervals for 44 US children's hospitals. And here were our study variables. And I think just for sake of time, I'm going to kind of go through that pretty quickly. But what's important here was, and this had not been done yet, and I'm just wondering how people hypothesize about this. But think about all of our kids that, while they're at home, lost special education resources, right? I mean, maybe we had some patients that were attending special ed virtually, but I would have to argue that that's kind of not the same as going to school and being in your special ed program and having that routine and regular teacher every day. Do you think that those kids had higher mental health ED use and hospitalizations after school closure or lower? Well, we kind of hypothesized that, you know what, that's probably a big deal that a lot of our kids lost that support. So we hypothesized that their ED visits and their hospitalizations would go up for mental health. There was also in the literature concerns about kids with anxiety disorders. There's at least one person who wrote a letter, didn't have any data, but he was giving a heads up about children with anxiety disorders, and he was basically hypothesizing that our children with anxiety disorders may be less anxious while they work at home when they're close to their family, but heads up, when we start reentry to school, they may have more difficulties. And so we actually created a study variable to see whether children with anxiety related disorders had lower or higher rates of ED use following school closures. Here's our final sample. Denominator was huge, almost 1.9 million children. And across both time periods, you see hefty samples. And I slice it here with 2 and 3 encounters because the unit of analysis was the visit, not the child. But you see here that only a small proportion were repeaters. So that helped us to feel that our estimates of decline or percent increase in ED visits and hospitalizations was relatively stable. Okay, so did the percent change in ED discharges and hospitalizations differ between physical health and mental health? And the answer is yes, okay, across all. It varied by public health, physical health versus mental health. And here you see, okay, in the spring of fall of 2020, for all cause acute encounters, 44% drop. And then we see almost a 50% drop in ED discharges and about a 25% drop in hospitalizations. That was for all causes ED or hospitalization, okay? And then here, when we slice and dice it, those for primary mental health versus primary physical health, here we did find that encounters for any acute mental health care, that decline was 2.4 times less. It dropped only 18.7% versus physical health for 45%. When we looked at ED discharges for mental health, we saw 2 times less decline. It declined only 25% versus almost 50% for physical health. When we looked at hospitalizations, the decline for those from primary mental health declined 3.4 times less. It just dropped 8% between 2019 and 2020 compared to those for physical health. So if you think you were busy during the fall and spring and summer of 2020, you were absolutely right. And here we explored by season. And what's important here in this is that the decline in acute care counters for physical health remained low during those three seasons. But in mental health, we saw, okay, in the summer, only a minimal decline. The ED use for mental health was almost the same in 2019 and 2020, and when you compare the summers. But hospitalizations for mental health during the summer for primary mental health went up 5%. And when we look over time again, you see in the fall, again, hospitalizations for primary mental health went up 4.4%. And here's what it looks like graphically. Okay, And so basically, what we looked at here was, did ED use and hospitalizations vary by sociodemographic characteristics or medical complexities? And here you see again some affirmation of earlier findings. Among our teens, mental health ED discharges declined less, and among our girls, mental health ED discharges declined less. And here, when we looked at mental health hospitalizations, we see again a pattern that is holding up pretty well. Very little change in mental health hospitalizations among our teens, females, whites, and commercially insured when you compare 2020 to 2019. And no surprise here, what were the 5 most prevalent primary mental health disorders before and after COVID school closures? Among any acute care encounter, it was depression and suicide. And you see that as well in our ED visits, and you see that as well in our hospitalizations. And what's most important here is not only that those two continue to be the same, that again, if you look at it, it's about 50% of all acute care encounters are for suicide, self-injury, or depression. And here, what's really important is, remember, I got kind of frustrated and I wanted to know more about, well, what types of mental health disorders are driving use? And here you see, okay, here's our suicide self-injury, a 12.8% rise in hospitalizations during the spring fall of 2020. What's interesting here is also our eating disorders. Both ED and hospitalizations rose after COVID. And my speculation is that these kids still kept coming in because of metabolic abnormalities and weight loss. The other thing that was interesting is our kids with psychotic disorders had an almost 11% rise in hospitalizations. And remember how I hypothesized that maybe kids likely eligible for special ed would have higher rates of ED and hospitalizations? Well, I was absolutely wrong on that hypothesis. We see here that they stayed out of the emergency room. Their reduction was 42.2% for ED, and hospitalizations were down 20%. And here for anxiety, only a moderate decline when you compare pre-post. And here what's most important is what we looked at here was those top 4. In the blue line is suicide and self-injury. And we looked at seasonal variation. And what's important here, when you look at ED discharges in the summer 2020, there was a rise of 22.6% for suicide and self-injury in the summer. And how about hospitalizations? And what's important here again is the suicide self-injury line, the blue line. And you see in the summer a rise of 20%, and in the fall of 2020, a rise of 42% of hospitalizations. And that's compared to the prior year. And then here, the question of, well, if there is this rise in ED use and hospitalization for suicide and self-injury, the next question is for whom? And so I tested the patients of our programmer, but he ran it, all of these descriptive statistics by sociodemographic characteristics as well. And once we had the findings, he didn't think I was that crazy. And what we see here is that for children, for hospitalizations among teens, you see a 43.8% rise for hospitalizations among teens for suicide and or self-injury in the fall of 2020. And when you look at by sex, and you look among female hospitalizations for suicide, self-injury, you see in the fall of 2020 almost 50% rise. So with this data, the advantage of using large-scale administrative data is that you can relatively quickly turn it around and analyze it. But again, this is hospital discharge data, so not all ED visits were underestimated. We only had discharges. Mental health hospitalizations are underestimated because these are hospitalizations admitted to children's hospitals. So we don't have information about kids that went to the ED, but then got transferred to, for example, a freestanding psychiatric hospital. It's not generalizable to other healthcare systems serving children. And what's really important here is it's again discharge data. So, clinically, there's so much more we would want to know about the child, the parent, and the community level to get beyond research questions that are much more just descriptive. But nevertheless, what's really cool is with this data set, we found that following COVID-19 school closures, that suicide or self-injury and depressive disorders continue to drive acute mental health encounters among 44 US children's hospitals during a time of additional strain on our children and families, as well as mental health systems. And remember our graphs, what we found was adolescent females were particularly vulnerable, as evidenced by their substantial rise in ED discharges and hospitalizations for suicide or self-injury in the summer and fall of 2020. So what are the implications? You write a paper, right now this paper is under review. It was pre-recorded for the Academy meeting. But what I'm hoping is that that if it gets published, that it can be used to further support public health strategies for children. When thinking about children, that we think also about mental health during the COVID pandemic, and particularly around placing greater emphasis on suicide risk reduction, especially for our adolescent females. So future questions, just a few. Remember we had that national survey that started to give us a temperature of the impact of types of classroom instruction on child mental health. So further work needs to be done there. What is the impact of school reopening on COVID-19 spread? I think that's pretty relevant, at least in LA Unified. And I know in our clinic, we have parents saying they're really worried about their kid coming home bringing a Delta variant, even though their family's fully vaccinated. There's a lot of concern about what is the extent of worsening of disparities and its impact following reentry to school. Things about disparities in education, mental health, and physical health. And this is quite relevant given what's happening in Congress right now, is what is the impact of the loss now of our COVID-19 financial supports to family supports and businesses on child well-being? And for those people who are interested in putting in a grant, this is a notice of special interest. This came out probably about 6 months ago. What's totally cool is NIMH and NICHD are purposefully asking for grant applications right now to understand the mental health impact of the COVID-19 pandemic on school-age children. And they're particularly targeting our young elementary school kids, primary care and pre-K 3 through 12 years. It's going to be really exciting. I think the first batch of grants are going to be reviewed probably in mid-October, early November. And hopefully more grants will go in over the 3 cycles per year. But this is a great opportunity where, hopefully we can really generate a new body of research to look at the impact of COVID on child mental health. So with that, this is how to reach me. And any questions?
Thank you so much for that wonderful talk. I have a question, and please, folks, if you have questions, please feel free to put them in the chat so we can have a discussion. So, and Bonnie, do you mind to
Oh,
stop
I'm
sharing my
sorry.
screen. So let
I'm
me
sorry.
keep going. No worries.
That's so funny. Our Zoom etiquette. Yes. Sorry about that. Hi, everybody.
Hi, there's everyone. So my question is, we're seeing at our Child and Adolescent Services at CSFG, which is a public hospital. So we see children who are publicly insured. That the minute we switched over to telehealth, we had a huge uptick in children coming to sessions, and it was great. It looked really great, and then it plateaued, and then it just dove, just descended. And so now we're at, reaching 50% of the children and youth and families that we would normally work with. We're only seeing about 50% of them. And at the same time, we have a long wait list, people not coming in for their intake appointments, and severity going through the roof as you presented. And I'm wondering if you have any recommendations for just.
Yeah. It's funny. I think it's also a really important research question. Do you know what I mean? Because when I listen to you, my first question is kind of what type of care were they getting? So, for example, like we have pediatric psychopharm clinic, and telehealth has worked very well with that, because it's just med checks, right? And so, in fact, we've had less no shows, but it's just medication clinic, right? So I would be interested in like your findings, like if we stratified it by the type of care, were you trying to continue therapy, or was it combined treatment, or was it just these med checks, right?
Yeah, I mean,
Because therapy, right? And the other thing too is telehealth is a mixed bag. We're doing a statewide evaluation of crisis intervention programs in California, and just like some of the other studies where you didn't think you were going to look at impact of COVID, but you were already in the field. We're hearing from providers on qualitative data really mixed feelings about telehealth. Do you know what I mean? Some parents don't like it. They want to come in. Therapists feel that they really can't connect or have the same relationship. Um, so I think eyes wide open. Do you know what I mean? I think there's mixed uptake and engagement and sustain of telehealth, right? And what makes it even more complicated is that reimbursement for telehealth continues to change, right? So if we were to do that study, one of our threats to external validity would be we'd have to monitor the benefits of, like in your population, Medicaid, right? You know, what are they billing and what are we getting paid for? Um, because that too is a source of tension, right? Um, um, Across healthcare centers that are feeling that they have to pay for the lights, so they want to bill comparable, versus insurance companies that say, no, we're just going to pay for the visit and not keep your lights on, right? So, what you've asked and what you've observed, um, I mean, we'd have to kind of tease out all kinds of research questions um, to try to understand the mixed findings that you have, right? And for you, why did it dive? Well, can we line that up to school openings, right? Or school closures? Are they getting more mental health care in schools so they don't have to lean so much on us anymore? I don't know.
I appreciate that. Thank you. Data's key.
To be continued. Other good questions, because when I started the talk, this is very humbling. I'm not the expert. I'm simply sharing data and sharing with you some of our recent data. I see a hand.
If you have a question, please unmute yourself. I'm trying to track who has a raised hand, so go right ahead.
I'm not seeing a raised hand, but if I'm interrupting
Oh,
and cutting,
so, and go ahead,
yeah, I'm
say
Nikki.
something.
Hello.
Hi, Nikki.
I just wanted to really thank you for that really integrative presentation of the epidemiological data and using the naturalistic, um, Ohio data on different policies and really leveraging that and mix with the kind of health records data. It's just so comprehensive for the picture, and it really helps us see how one can present a certain message around transmission that's all about school closures, but yet thinking about that there's correlational factors that might not
Yeah.
be school closures being causal. Just really, really
Well,
fabulous to have that.
it's also rapidly evolving. I mean, I felt like it was like a ticker tape parade,
Oh yeah.
just monitoring the studies. And I think what's happening right now that's a challenge is if you talk to the editors of the major journals, they're flooded with COVID papers now. Do you know
Right.
what I mean?
Yeah.
So there's no way that they can publish everything. So even the stuff I shared with you today, it might never get published
Mhm.
just because
Yeah. Inundation.
journals are saturated. So we'll see. But it is quite a challenge. And then the other challenge is, the early stuff was capitalizing on natural experiments, and but now I think the more quality data, which takes more time, might be replicating prior findings, but in a much more robust way. Does that make sense? And I
Yeah.
just feel like we're just at the beginning of it, and so it'd be really interesting to see, like, when NIMH and NICHD starts funding these grants in this next round in this next couple of years. Like, I just feel like we're just at the beginning of it, right? And all I'm sharing with you is kind of data red flags. And then, still being on call and in clinic and all of those good things. Um,
And of course, that time temporality, like the beginning of the pandemic was one experience, mid is another, the
yeah,
enduring chronicity is another.
yeah,
And, it's
yeah.
just hard to even know how to look at the data.
Yeah, and I think the other thing too, since we're among Californians, is did you see the distribution of the recall vote of the red and the blue counties? And so how is that correlated with variation in school district policies, right? So, you know, I'm, happy to talk more about other collaborations, because I do think in some ways we also have a really important natural experiment in the state of California on school district policies and vaccination rates. And we know very, very little about um, this polarized political context that's affecting our school district policies, right? I mean, that's fascinating. So, you know, my contact information is on the email, but it's something, we should consider as Californians to put in some kind of proposal statewide. Other questions or thoughts? I know it's 1 minute to one, I think, or so. So, and it's not easy to be training under Zoom. So kudos to you guys for hanging in there virtually.
Kudos to you for leading.
Oh, you're welcome. And I'm gonna go to telehealth in just a few minutes for pediatric psychopharm clinics. So I'm right there with you.
Yeah, no, I'm just processing all the information and thinking about all the different correlates that we might, think about. What you said, I think is, resonates. It resonates with me. It's very powerful. What are the different ways that school districts impede or enhance mental health and access to mental health supports, based on,
Yeah,
how much funding those
yeah,
schools get, what is the
yeah,
cost, right?
yeah. And I think we shouldn't be shy right now. I mean, we're the ones that care about child mental health. So, and we're really well positioned in two very large public universities.
Yeah.
So, you know, I'm happy to continue exploring future collaborations. This is going to take a big team. So anyways, don't hesitate to reach out if people want to follow up and think about some future work together.
Thank you so much for offering that. This is fantastic, and thank you. Lots to chew. And I hope you can see in the chat.
Yeah, that's really sweet. Thanks, you guys. Thanks, you guys.
Appreciation. Take good care, everyone. Lots to think about, and enjoy your telehealth session.
It's real time. Okay, guys.
It's real time. You're on.
Okay.
Take good care, everyone.
Bye, everybody.
Bye.